When it comes to cancer, early detection is key, and that's certainly the case for breast cancer. Today we're diving into the ways doctors are detecting the disease using technology, as well as the various ways of treating it. That's next on Being Well.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
Thank you so much for joining us today for Being Well. I'm your host, Lacey Spence, and today we are talking about breast cancer and ways to detect it. And our guest today, we've got Dr. Yaniv Cozacov.
Yes.
Yes, from Horizon Health. Thank you for making the trip. Much appreciated.
Thank you for having me.
Of course. And so today, as we're talking about breast cancer, very prevalent among women is what we normally hear. How common is breast cancer in the U.S.?
Well, it's pretty common, and the U.S. is entirely North America has a little bit higher risk of having breast cancer than the rest of the world, and that has to do with our lifestyle. In North America, women get their first period earlier than the rest of the world. We have pregnancies later in life. We know that having early pregnancies are actually protective for breast cancer, but our lifestyle, we have pregnancies later on in life, and there's less lactation of newborns that also increases the risk. Overall, in America, there are 260,000 new breast cancer cases every year, and it's a pretty and about 40,000 women die each year from breast cancer. The numbers are 1 out of 8 women, so that's a lot. So if you kind of live on a street, if you look at your house and your neighbors on either side, the likelihood of having breast cancer is 1 in 8. That's pretty high.
Yeah, and so as we're talking about breast cancer, any type of cancer, early detection is obviously key. So what are the ways that we are going about finding out we have breast cancer? Well,
there's several ways of finding breast cancer. One is, like you said, is about early detection. But if we don't do that, the signs of having breast cancer is just, if you feel it by yourself, one is just feel a new lump in your breast, a new mass. That usually it's hard. It's kind of fixed. It doesn't move around with the skin. It's a little bit deeper than the skin. Sometimes you see skin changes. There's we call that dimpling of the nipple, where the nipple kind of gets inverted, goes inside. Mm-hmm. Sometimes you see a little wrinkle on the breast, or just the curvature of the breast is not as even as it used to be. So these are kind of signs that you might have a mass there that we need to check out. The other signs are sometimes itchiness or some scraping, kind of have like eczema on your nipple, and it doesn't go away. Some women put creams, moisturizers, you think it's just dry skin, but it doesn't change, it stays there for several weeks. These are signs that are kind of concerning, and we have to go and look for breast cancer. Once you have those signs that you feel a lump or you have those skin changes, you decide to go to the doctor, the next step would be to diagnose it and see what that lump is. If it is breast cancer, or sometimes it might be something else that's not breast cancer. Mm-hmm. The way we diagnose it is we do a biopsy. We take a little piece of tissue and we send it off to the pathologist. He looks under the microscope and then we find out this is cancer, or this is something else. Maybe, could we just, sometimes there's really benign lesions, especially in young women, called fibroadenomas or lipomas and so sorts. So it's really, if you have those symptoms, it's really important to come to the physician and kind of try to differentiate and see what's causing that.
And so as there's options for doctors to look at masses, look at the breast, where does 3D mammography kind of play into this?
So going back to the original question, how, the screening for breast cancer. So screening for breast cancer, the word screening means looking for cancer in a place that there are no symptoms. You don't feel a mass, there's no discharge from the nipple, there's nothing that would suggest everything looks fine on the breast. And we're basically kind of looking for trouble. We're looking for breast cancer before it gets to that point, because at that point, if there are those changes, if there is a mass, it might be a later life and the breast cancer might be more advanced. So we're looking for breast cancer before it causes symptoms. And the best way to screen is doing mammograms. There's different types of mammographies. One is the conventional, the regular that we've been using for decades now. Mm-hmm. It's just a 2D mammography. Basically, we're putting each breast and we're taking x-rays, one from the side, one from the top. The newer modality that's been approved by the FDA since 2011, but it's actually been around for 30 years. It's what's called this 3D tomography or 3D mammography, where instead of having just those two images, one from the side, one from the top, we have an X-ray machines that kind of goes around the breast and takes several images. Mm-hmm. And what it allows us to do is that, one, it's more accurate, it has finer images, but kind of like you see in the movies where they kind of rotate 3D models. When you take those two images, you're just seeing one plane. When we have those 3D mammography, we have those several images, we can kind of turn around the breast and kind of look at it in 3D. What it allows us to do is, one is that when we see some abnormality in the 2D images, into 2D-dimensional, then we would bring the patients back and do more images, trying to figure out what we're looking at. So now with the 3D, we don't have to call you back because we have those extra images that we need to begin with. Oh. So there's less callback. So it means we know more what we're looking at. Mm-hmm. There's less what we call callback, meaning we don't need you to come back for getting another x-rays. That way we're less anxious, we're causing less anxiety, we're more accurate. On top of that, in the 2D mammograms, what wouldn't see so much suspicious, you wouldn't see much. On a 3D, kind of new things appear. It gives you another dimension, and we diagnose up to 30% more cancers using the 3D mammography. So the advantages are twofold. One, there's less callback, resulting in less anxiety, less procedures. You don't have to come so many times, you get your answers right away. And the second thing is we actually diagnose more cancers at an earlier stage. So that's a real big advantage of having the 3D mammography.
And so when you hear the term stereotactic, is it that type of machine, or is there a difference? So stereotactic mammography, we use the word stereotactic when we're doing biopsies. Okay. Stereotactic is the way for us to guide the needle for doing the biopsies. So first thing to know about the mammograms, there's different societies, different recommendations. We go by the National Comprehensive Cancer Network. This is the network with all the physicians, all the associations, and they give us guidelines pretty much for the management of all types of cancers, not just breast, but also colon and skin and every cancer there is. And their guidelines, when should you get a mammogram? When should you start getting those? The chances of having breast cancer increase with age. So the older we get, there's higher chances of getting breast cancer. So the current NCCN guidelines, they recommend, and we agree with that as surgeons, the Surgical Association and the Radiologist Association, we agree with that you should start having mammograms looking for breast cancer at the age of 40. And then every year after that, up until the age of 75. After the age of 75, you kind of talk to your physician, is it really needed? It really depends on other factors, but from the age of 40 to the age of 75, you should have a mammogram every year. And this is free. This is paid by all the insurance companies. It's mandated that they all pay for this. Even if you don't have insurance, it's really not expensive. You can shop around and find a place that will do it for not a lot of money. But
It is for everyone. It is free. It's accessible, and it shouldn't be a big deal. And just a word out. There's so many people using it. We do so many mammograms every year, millions of them. People utilize it. So if there's out there the people who haven't, or they're over the age of 40 and they haven't done the mammograms this year, go get it. It's free.
And so we start the mammograms at 40. Is that when you should also start the self-examination, or does that need to go earlier?
Well, self-examination, there's no point doing it every 3 months. We found that there's a lot of studies that say that it's really not the best way to find cancer. The really best way is to do those mammograms every year. But I would suggest to young women in their 20s and their 30s, kind of do a periodic breast exam, meaning every 6 months or so, just to get to know the breast. So if there's a new lump, especially when they're young, they can kind of, just familiar with the breast and they know what it is. Because there's a lot of breasts that have a lot of what we call fibrocystic changes. The different breasts are different, there are different textures to it. So just get to know your own breast, and if there's if there's a new finding, then you feel something's different, then you can go to your doctor. The self-breast exam, you can start doing it in 20s, early 30s. A physician you should go to your physician once a year to get what we call a clinical breast exam. So your primary care can do it, your OB can do it. But we know that the most important thing, the one that finds the most cancers, is getting that mammography.
Gotcha. And so for patients who maybe have cancer in the family, how should they go about these testing? Because I assume if it runs in your family, you're at higher risk. Yes.
So we're talking about getting a yearly mammogram after the age of 40. This is what we call for average risk women. So
Okay.
this is the average risk women, meaning every woman in the United States or North America in general has a 1 in 8 chance of getting cancer, breast cancer. If you're talking as someone who has what we know about, what we hear a lot about, the BRCA genes, BRCA, BRCA1, BRCA2, there's other syndromes in the family, other genes that are associated with it. The biggest thing that I would say, it's really individualized because it depends on what type of cancers run in your family. I would suggest if you have a lot of family members, your mom, your grandma, your cousins, your aunts, who have breast cancer, the best thing to do is talk to your physician and then get to see what's called a genetic counselor. A genetic counselor will go with you, run with you the whole family tree, and see how many cancers and what types of cancers. Because it's not those genes are not only associated with breast cancer. If they're associated with pancreatic cancer, with colon cancer, uterine cancer, ovarian cancer. So, if you have a lot of cancers in your family, the best thing is to talk to your primary care, and then maybe see if you need to see a genetic counselor. And then the genetic counselor again will run through the whole family tree and then talk to you whether we need to do genetic testing. Is there indication for that, or no? You just have sporadic cancer in your family, and there's no real risk of having a gene.
And what has been kind of your thoughts as you've got to see technology evolve over the years to be able to use gene mapping to detect this?
It's very good. So there's a lot of anxiety with genetic testing, and I think it's unnecessary anxiety because with the genetic testing today, every day we find out more genes, but over the last 20, 30 years, there's such a development in understanding genetic and molecular biology. And we know so much about a lot of genes. And if you know what gene you have, if you have a lot of cancer in your family and do find out that you have a gene, that will help us direct the treatment or the management or what are we looking for. We're talking about BRCA genes, but remember there's 260,000 new breast cancers every year in the United States, and about 5% are associated with those genetic syndromes. So that's a lot of people. It is something that, if you have a family member, I think you should, talk about it and talk to your primary care and maybe even see a genetic counselor.
And for those who have the BRCA gene and they're younger patients, is there a certain course of action that you take, whether it be removal of the breast? Is that kind of a popular option or no?
Yeah, we call that the Angelina Jolie effect. So, she has the BRCA gene, and
Sure.
She underwent what we call a bilateral mastectomy, removed both breasts, and she went on reconstruction. Again, it's so individualized and really depends on how old are you and the cancers in your family. Even if you have the BRCA gene, it's going to be a very individualized course of action. It really depends. There's a lot of factors into it.
Okay.
So if you have that, yeah, you got to talk to your surgeon, talk to your physician, and get a treatment plan that's good for you.
And obviously it makes sense that we talk a lot about, women, with it being 1 in 8 women, but how prevalent is this in men as well?
So it's not that common,
Okay.
But about 1% of all breast cancers appear in men. So it does happen.
Mm-hmm.
And if you have a man in your family, the important thing to know is that if you have a man in your family, if a male that had breast cancer, then there's a high likelihood of you actually having the BRCA gene in your family, because it's over in men. A lot of times it is associated with the BRCA. So if there's a man with breast cancer, all his family should be tested for the BRCA gene.
Wow, I didn't realize that.
Yeah.
And so you were telling us earlier that our lifestyle can be a trigger for breast cancer. What are some other causes or things that have been linked to people developing cancer?
So there's some people who have cancers when they're young adulthood, especially like lymphomas or thyroid cancers, and they get radiation to their chest. That can increase the likelihood of breast cancer. Again, having a family history. And again, there's other genetic syndromes that are associated with it.
And so after you're diagnosed with breast cancer, what does, I know it's individualized, but what does a generic treatment plan kind of look like for folks?
So let's start with this. So let's say, if you have, like we talked in the beginning, there are signs and symptoms that you have. If you feel a breast lump, then, you come to the office, we take a piece of tissue out of that, we look at it and see what it is. But for the screening mammogram, so for people who don't have breast cancer and they're getting their annual mammograms, what happens when you get an abnormal mammogram? So we see something's going on. Most of the times what we see are teeny tiny calcifications. And you can see it in the picture, it's kind of circled. If you can zoom in on it, you see those white specks on the mammogram. They're calcifications. They're little calcium deposits, and you can see the rest of the breast that doesn't have any of those. So let's say we find those. This is what we call an abnormal mammogram. The next step we'll see, so those calcifications, they're not necessarily cancer, but we know they are associated with cancer. It depends on the way they appear, but usually the rate of having cancer is around 2 to 10%. So it's really not a lot. But so when we find those, the next step would be is do what's called a stereotactic guided needle biopsy. Basically, we use the same images of the mammogram, and we guide a needle to that area where the calcifications are. And then we use a device with the needle, and it's really simple because it's the same as getting a mammogram. We come in, you go into the mammogram room, we find the lesion that we want, and then basically the steps of getting a biopsy is pretty simple. We clean the area with soap, and then we put some numbing medication, and we put a teeny tiny nick at the skin, about 4 or 5 millimeters. And through that little nick, we get a needle in and we guide it to exactly using the mammograms, the x-rays. Once we get it in front of the area that we want, we do the biopsy. The needle basically kind of sucks it in and kind of has a little knife that goes back and forth, and get that pieces of tissue out. And then once we have that, and we get the tissue, we'll do another mammogram, make sure that we got the area that we want. The next step, we get an X-ray of the specimen, make sure that it does have the calcification, that we got the area that we want, and then we send it off to the pathologist. And what you can see is that in this case, you can see the cells, they kind of range in circles. These are the ducts, the milk ducts, and in this case, this was normal breast tissue. So the evolution of surgery-wise, as far as the treatment for breast cancer, we became less and less invasive. Back in the day, what these little calcifications would cost you going to the operating room, having a cut on the breast, and having to call what's called an excisional biopsy. Nowadays, we just do it with a little needle in the room under local numbing medication. So it's really the advancement is becoming less and less invasive. We're detecting more and more cancers and at an earlier stage.
And so as you go into treatment, are there benefits or pros and cons between like chemo or radiation, or chemo and radiation? What does that kind of look like?
So the chemo and radiation, those are things that really depend. So we talk about breast cancers in generally, but there's a lot of different types of breast cancers. There's dozens of them. So it really, if you hear a lot of the news about individualized medicine or or targeted medicine. We basically, we study the cancer, the type of cancer. If we do find cancer, we study what type it is, what its molecular genetics are, what are the genes that are mutated in it, and we really give a targeted therapy. We have chemotherapy that's very specific to very specific types of cancers. And really the whole discussion kind of, at this point, either you're a surgeon or you're an oncologist, or you have a quarterback who kind of manages everything and kind of makes sure that everything goes in the order it should. Mm-hmm. And then we get you through that targeted medicine. Usually what I say to patients is that, with the come the first time with an abnormal mammogram, our plan is to get a biopsy, get more information, see what we're dealing with. Once we know exactly what we're dealing with, we can form a plan. Once we have a plan, we execute the plan, whether it's surgery or not, or chemotherapy, whatever it is, and then we move on, and then we get over the cancer, and we move on with our life. This is pretty much a sum up of what happens once you come with an abnormal mammogram.
Any questions that maybe I should be asking them before I do this? There's a lot to weigh here for my treatment options.
Yeah, so the important things to know that, let's say we're talking about surgery. It comes down to the point where surgery is offered, mm-hmm. is on the table. There's two different types of surgery. There's what's called a lumpectomy, where we go to the operating room, we make about a 5, 6, 7 centimeter cut on the breast, and then we go in and we take that cancer out with what we call margin. We take the cancer out and a little bit of surrounding, make sure it's completely out. And this is called a lumpectomy. We can do a lumpectomy when the tumor is small, mm-hmm. and the end result is that after we do the surgery, it's not going to cause a big deformity of the breast. So it really depends on the size of the tumor relative to the size of the breast. The other surgical option is called a mastectomy, where we remove the whole breast. The most important thing to know about that is that if mastectomy is on the table, it's mandated, meaning you are to get, if you get a mastectomy, you are eligible. You're going to get a plastic surgeon, discussion with a plastic surgeon, and you are allowed to have a breast reconstruction of your choosing. So it's important to know that anyone who is having a mastectomy, a reconstruction is in that bundle. It's included. So this is something you should know. And again, it's very individualized whether going lumpectomy or a mastectomy. It really depends. There's a lot of factors weighed into that, and mm-hmm. this is a discussion that you should have with your surgeon. To find your surgeon is the same way you find any other doctor. You go there, you see him. If you feel like it's the right person for you, then that's okay. If you feel like something's off, you don't get that, the rapport that you were expecting, then it's okay to go find someone else. You're not going to hurt your doctor's feelings or that doctor's feelings. No, you shouldn't. Yeah, no. Yeah. Sometimes I do offer my patients, I say, you're not going to hurt my feelings if you're going to see a second opinion. That's perfectly fine. That's within your right. And sometimes you should, If you don't like what you're hearing, it's okay to get a second opinion, There's, medicine is an art, surgery is an art, and there's different ways to do things. And I feel like there's sometimes that we go into the doctor's office and maybe we're a little bit intimidated by, the whole situation, what have you. But like you said, it's very important to speak up for yourself. Absolutely. The whole thing what we're doing with the mammograms, yes, we are finding a lot of breast cancers. Yes, we're finding them earlier. But the downside of that is like we said previously, that the chance of having cancer in an abnormal mammogram, sometimes it's low. It's around 2 to 10%. So we're doing a lot of biopsies. It's a lot of anxiety. And the first thing I talk about patients is kind of, first of all, let them get off their mind. What are they feeling? What are they thinking about? Mm-hmm. And kind of going down to the plan is I don't want them leaving my office and asking what if and what if and what if. There's always those what ifs, and it's kind of going down a rabbit hole. Yeah. And so we form a plan where we do the biopsy, we get more information. Once we have all the information, we can make a decision about what the treatment's going to be. So until that point, until we have all the information, there's no point going down that rabbit hole and asking what if and what if. So, when you talk to your physician, it's really important to kind of mitigate that anxiety and the actions that's coming with it. Definitely. And so in our last minute here, do you have any advice that you'd like to leave our viewers with at home? Absolutely. Get your mammogram. Yeah. There's millions of women getting it every year. We save, we're doing breast cancer surgery is very common surgery. It's one of the most common surgeries we do. Take advantage of that. It's free. Get yourself doing it. Get your mom, your sister, your daughter, anyone, your neighbors.
Find your 7 other friends.
Find your 7 other friends. It takes a village.
Yeah.
And the way we say it, there's women around walking around with breast cancer, and if we do enough mammograms, we're going to find those women and save their lives.
Very well put. Thank you so much for being here. Appreciate it.
Thank you so much.
And thank you for joining us today for Being Well. We will see you next time.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.